mostly what we're going to be talking about today is, how you can, and I'll get to this slide here. So what are we talking about today? So, as from an aging perspective, how we can look and feel our best. And it's not just aging, but, sort of preventative as well we could talk about. And how our department and medical spa can fit in to help you do this. So, and I try to avoid talking with a lot of jargon and stuff like that, but if I say things which are doctory that don't make any sense, then let me know. Okay. All right. So who are we? I've been here at the clinic almost 9 years, and we are a medical spa that's run through the Billings Clinic. So this is kind of a different thing that the clinic delved into with us. Before I got here, it took a little bit of imagination for them to get away from, colonoscopies and invasive heart surgery and stuff like that to what we were doing. But I'm glad they did, and it's been a great experience. So our department is comprised of me. I'm a facial plastic and reconstructive surgeon. We have 2 registered nurses, an MA/esthetician, and a consultant. And anyway, we work as a team. We're pretty egalitarian. I'm pretty much the low man on the totem pole. So I get told what to do and where to be, which is why I was a couple minutes late here. So, and this is our staff. We've had a little bit of turnover. Gwen was actually working for us in Stephanie's position, but she has pretty awesome marketing and expertise, so she's moved back to her love, which is the marketing department. I'll try to stop doing that. So that's Stephanie there on the right, and Erin, Mariah, and Christy. Those are our nurses. So, as part of this talk, I was kind of looking back, and I think Christy's been with us almost 5 years, Erin probably 6 years, and Mariah 6 or 7 years. So they're pretty great team to have to work with every day. I'm pretty lucky. So what is facial plastic surgery? So first of all, a lot of people don't even know that it's a thing. So so it's a subspecialty of otolaryngology head and neck surgery. I know that sounds like sometimes we're called ENTs. We prefer to be called otolaryngologists because just like you don't go to the cardiologist and call them a heart or the gynecologist, you get my drift. But the proper name of the specialty is that. And basically, our job is to do medical, but mostly surgical treatments of things in the head and neck. And I spent 7 years at Hopkins, both with otolaryngology and then facial plastic surgery. And then there's an otolaryngology board exam. And then after you've been in practice 2 years, you can take a facial plastics exam, and that you have to submit a bunch of cases, and then there's a written portion, and there's an oral portion as well. And I just did I had my 10-year recert in otolaryngology a couple years ago, and then this past year I just redid facial plastics. So it's pretty rigorous, and pretty much I do whatever a general plastic surgeon would. I just confine my practice to the head and neck. So what sets us apart? I mean, I'm pretty passionate about this. The clinic doesn't do things the way other medical spas in town do, where they hold us to the clinic standard. We have the clinic logo, and they take that pretty seriously. So, we're a not-for-profit, so we don't work the way most medical spas do. We're JCO certified. We have magnet certification, so our office runs that way. So it's just a little different. And then I think that sets us up well for customer service, because when we discuss something with you, we're really about what's best for you as a patient, not really about what's best for our bottom line or for our office, okay? So, and then our level of expertise. Again, I've been here a long time. I've been doing this a long time. And you'll see that even though our menu is pretty long, my expertise is really the head and neck. And pretty much whatever we do, if you went elsewhere, you would probably get a lower level of somebody doing it. So our registered nurses do a lot of procedures that probably somebody who did a weekend course would do, and they've been working with us for 6 years. And I think we give people really good outcomes. But part of being part of the clinic is you can't, you can talk about yourself, but you can't promote yourself too much. And there's a lot of things that we don't do that other offices do, which for me is a good thing. Because if I wanted to be a salesman, I would have been. And I just like taking care of patients. So anyway, so let's get to the thick of the matter. What can I do to slow the aging process, and how can our office help? So there's two types of aging. There's intrinsic aging, meaning not much you can do about, and then there's extrinsic aging. Those are things that we can really help. We can help you with the intrinsic aging as well. And I'll have another slide that kind of shows this, but unfortunately with age, once we reach about the mid-30s, we stop making a net amount of collagen. We start losing collagen. And then our skin elasticity decreases, and that leads to things like fine lines and wrinkles, thin and transparent skin, loss of subcutaneous fat, excess laxity, and then we also lose a bunch of bone in our cheek and jaw region, and that gives us the aged look. So when we're young, we're kind of a triangle. As we get older, we make more of a square, as things settle. So we talk about that a little bit. And then extrinsic aging we'll talk about. These are things that you absolutely can do something about. Sun exposure, smoking, facial motion, and gravity. We'll talk about that. All those, I wish I could stop hitting that in order. So sun exposure. So we live in a beautiful place, right? And I wouldn't advocate not being out in the sun. And being out in the sun is actually important for vitamin D, and there's some health effects, honestly, that are part of it, but everything in moderation, right? So the sun actually does specifically break down collagen. It does produce free radicals. What free radicals are they're unbalanced parts of the cellular membranes which break down cells and produce aging changes. DNA is what is replicated every time your skin cells replicate, and as they replicate, they can accumulate errors, and the sun advances that process. The immune system effects are plus and minus. They've done some studies where people that don't get any sun, it actually is bad for their immune system, and it's bad for their cardiovascular health. But again, if too much of a good thing, it does cause some issues and suppression of your immune system and your ability to heal. And then it can induce cell death specifically, and it's the number one cause of skin cancer, both melanoma and non-melanoma, meaning basal cell and squamous cell cancer. So we take care of those too. We've got a great dermatology department here and a Mohs group that does a lot of surgical excisions. We usually get involved with that when it's a bigger hole than they would like to handle. So hopefully not need that. So smoking, this absolutely you should not be doing. And e-cigarettes, I'm not a big fan of those either, but they're better than smoking. So smoking is just a terrible thing for aging. It's a terrible thing for healing. It does pretty much, you name it, it's responsible for it. So it restricts blood flow. It increases the degradation of collagen or collagenase. It reduces the body's store of vitamin A, which is also important for skin protection. Interferes with absorption of vitamin C. And then you can also get lines specific to puckering related to cigarettes. I honestly, in most circumstances, I can pick out a smoker. I don't even have to talk to them, just because I can know what their skin looks like. And we all know it causes other things which are probably more important: cardiovascular risk, stroke risk, and a bunch of other things, but we deal with these issues. So gravity happens unless you're on the space station. So again, we lose collagen elasticity, and gravity contributes to that. And facial motion. This is actually a device I saw. It was a gimmick on the internet. And I've had patients come in and they tell me that they work their facial muscles all the time. They work their platysma. They don't understand why they're getting more wrinkles. Well, a lot of wrinkles in the face are related to motion. So repetitive motion over time leads to a predictable pattern. And this accounts for why Botox is effective. So the skin as we age, you can see from the 20s, 30s, and 40s, basically the superficial layer on top there is the dermis. And then there's two layers of dermis. There's the superficial dermis, which is the orange. And then the little things that look like tree branches, that's the deeper dermis. That's actually mislabeled. And then we have the subcutaneous fat, which is at the bottom. So what we see is that the skin thins and gets irregular. And then we lose collagen. That's the little tree branches in the middle. And then we also lose our subcutaneous fat. So what we do in our office is help you restore that through various mechanisms. So again, as we age, collagen goes down, collagenase, which breaks down collagen, goes up. So the intrinsic factors contribute to that, extrinsic factors contribute to that. So what we're really trying to do is break up that pattern and instill some positive changes for you. So things you can consider doing to slow the aging process. I should probably take some of this advice myself. Get plenty of rest, really does help. Limit your sun exposure. Again, you live in Montana, and there's a lot of health benefits for being outdoors, doing things, but wear your sunblock. We say SPF of 30. The interesting thing about sunblock is at a 30, you're getting about 90% sun protection. 50, it's like 91. 70, it's like 92. So you just want to wear, a 30 is really the big thing. So, and use moisturizer. Grape looks better than a raisin, okay? And then get in a good skincare regimen. So I'm pretty basic. We have skincare products at our office, and the folks that work there know a lot more about that, the little details than I do. My big thing is retinol or tretinoin. Those are vitamin A derivatives. Retinol is available over the counter. Tretinoin is usually by prescription. So those increase skin cell turnover, promote collagen production, and they actually enhance the results that we give patients. So a lot of times when we do a procedure, you think about it just like you're running a marathon. The thing of the retinol is like you're getting a run or two in a week just to keep yourself in shape. And wearing makeup that's good for the skin. You just don't want to cake things on. That clogs pores, causes problem. Diet and exercise. Those things are really important for living longer, feeling better, looking better. And of course, my segue, employee cosmetic services there. So one of the things we get a lot from patients is I feel a little guilty about doing cosmetic procedures, and it's a common sentiment, but you have to think about that. I'm sure most of the people in this room have taken care of other people, probably put other people's needs ahead of their own for a long period of time. There comes a period of time where it's okay for you to do something for yourself. And then again, people get their hair done. No one misses an appointment with their hairstylist like ever, so I know that's an important thing. You wear makeup, nice clothes, you exercise, so just look at this as an extension of that. And we want you to look and feel natural, so we never want you to look like you're done, and we'll talk about that too. And so, again, I'm afraid I will look done. So unlike in TV, we don't want people to look done. We live in Montana, Wyoming, we take care of those patients. No one wants to walk around Glendive and be like, people staring at them. So unfortunately, if you do good work, not many people know about it because no one talks about it. For some reason or another, when people have body work done, they're more free to talk about that. I don't quite understand, but no one talks about the rhinoplasty or the facelift in general, which is good. So we want you to look natural and rested. And actually, interestingly, as a segue, they did a study where they looked at people in LA versus people in New York and the style of plastic surgery that they liked. And the people in California, that area specifically, like a more done look. And I get a lot of patients that come in and they don't want to look like this person or that person or this person. And so we try to reassure them that we don't do that. So there are some factors that lead to poor outcomes in facial plastic surgery. And so my job is, first and foremost, is never harm a patient. So we think about your safety first. We're not going to just do something again to make a buck off you when it puts your safety into danger there. So poor patient selection, patients with significant comorbidities. If you're on a left ventricular advanced device and blood thinners and stuff like that, probably shouldn't be thinking about a facelift. Active smoking or drug use, depending on the procedure. Sometimes we don't. I'm a realist. If you're going to come in for something little like a filler, we're not going to make you quit smoking, but if you're going to have something like a facelift, we will nicotine test you if you've been smoking, and you have to be off it for 3 weeks for the reasons I pointed out before. You don't need the procedure. So this is the fine line I walk. Everybody is their own worst critic. I remember there was this video I saw on Facebook or whatever where they had people draw a picture of themselves, and then they had a perfect stranger draw a picture of them. And the picture that the stranger draw was much, much nicer than the one they drew of themselves. So when patients come into the office, one thing I hate is like, well, what do you think I need? I was like, I've been married for a while. That's like something I don't walk into, So I'm like, well, what bothers you? I'm not going to tell you. I'll tell you if you don't need it, but I won't tell you what you do need. My job is not to pick you apart. So there's something called body dysmorphic disorder. This is somebody that pretty much is so hard on themselves that nothing I can do will make them feel better. The most common procedure that people have that with is rhinoplasty, actually. They estimate that almost 50% of people. I don't think it's quite that high, but I've had a couple run-ins where people have flown under the radar. Some practices actually have a psychologist for certain things they'll screen people through. But I was a psych major in college. I guess had a couple instances that hopefully I won't repeat, but you can usually tell those people. Unrealistic expectations. So, I need to make sure that you're set up for success. I like to say I'm a physician, not a magician. There's certain things that are possible and not possible. And one of the biggest issues that people get into, I think, is when we don't communicate well. And what they are wanting and what I can provide aren't the same thing. So we spend a lot of time talking to make sure that we're all on the same page. And then it's not you, it's me. So just like in relationships, a patient and physician is a relationship. And if we're sitting there and we're doing the consult, which we spend a fair time doing, and it's pretty clear that we're not communicating well, or there's just something about maybe my personality or their personality which doesn't click, I'll just be honest with them. I'll say, look, I'll give them, maybe a name of somebody else or something like that, but in kind ways I can. Because it's easy to be a good doctor, or what you think is a good doctor when things go perfectly. It's really, being a good doctor is about when things don't go perfectly. And if I don't have a good rapport with that patient, then that's going to be a bad thing. So that's why I don't parlay most of my things to other people. Like I do all my post-op appointments. I'm very hands-on with that because, again, it's my relationship with the patient that's important. I just want to make sure that they end up happy. So other things, poor procedure choice for the patient. We see a lot of that. Poorly placed incision, see a lot of that. Poor technique, see some of that. Over-tightening, pulling in the wrong vector. Those are things that can give you bad scarring, tissue necrosis, a bunch of other fun stuff. So, whenever I do something to somebody, especially an operation, I would say that I do that like 3 or 4 times because, I'll go over things with the patient at the time of the appointment, and then I'll do the procedure in my head and usually with pictures so that when we do the surgery, everything was planned and executed as well as it could. Still, being a physician is very humbling. I would say that I went to college to be an engineer, and machines react very predictably in interventions, people not always the case. And so that's why when you come in, people I can't give you a guarantee, I wish I could, but I say I wouldn't offer you something if I didn't think that I was going to give you a good outcome. So some examples of bad things, Kenny Rogers. Basically this is an old style coronal lift where they make an incision from ear to ear and then they did an upper eyelid blepharoplasty. So him on the left, he's a handsome middle-aged man. Has heavy eyelids, but a lot of middle-aged men do. It's very feminizing what he did. Again, that's sort of a Hollywood deal. Michael Jackson, we all know about this cautionary tale. He actually had a prosthesis on his nose for most of the end of his life because he had a hole there. So much surgery was done. And in fact, the surgeon who did all his rhinoplasties had his license taken away because he did a bunch of sham surgery on him. So it's kind of a sad situation. And then this is another example of overcorrected, overpulled, overdone kind of look. Gary Busey, he's always a little crazy to begin with, but plastic surgery did him no good. And then this is kind of a gal they always talk about in plastic surgery. She had a bunch of silicone and other fun things placed, some of which was placed in somebody's garage probably. But anyway, we don't want you to look like that. So what are some things that we target? What are some problem areas? So you name it. Wrinkles, brow sagging, upper and lower eyelid, extra skin and fat, nasolabial folds, marionette lines, which are these little lines here, jowls, redundant skin in the neck, fine lines and wrinkles, skin discoloration, rosacea, melasma. We take care of a lot of different things. So I'm kind of going through this from least invasive to more surgical intervention. So we have Christy King, she's a medical assistant who's going to nursing school. She also has an esthetician license, and she does eyelash extensions. kind of a weird thing to do at the clinic, but she is really, really good at that. She books out really far, and they just look great. You'll see a lot of pictures of our nurses. A lot of people, they just don't want to be on a public screen like this, so you have to sign things explicitly, so it's not like we don't have other patients, but they're oftentimes the face of our practice in many ways. So, and then microblading is something else that Christy does. So this is an alternative to permanent cosmetics, where she basically makes small entrances into the skin and basically makes the brows look fuller. And she does a really good job with that as well. That's not permanent, usually needs to be redone, but it does last a good amount of time. And permanent brow makeup is a little bit dicey as you get older, because your brow is going to descend, but then your eyebrow is going to be in the perfect location. And you'll come into me and you'll say you want a brow lift, and I'm like, I can't do that for you, because you're going to look like you walked in a surprise party. We just don't want that to happen. So, okay, so we talked about volume loss, and I'm throwing neuromodulators into that. So neuromodulators is basically Botox. You know, people when they hear it's a toxin, so they call it neuromodulator. And what I always tell patients with that is like, you take penicillin. Penicillin is something that is made in nature. If you took in high doses, it would be lethal. But we use it for a purpose that has a medical benefit. Botox is used for tons of things, from migraines to cerebral palsy, but we use it for wrinkles. And then improving volume. Again, a grape always looks better than a raisin, right? So a volume is an important aspect of everything that we do. So just to talk about Botox a little bit, you've probably heard about it. It's basically purified from Clostridium botulinum, which sounds really scary, but the doses that they use are infinitesimally small. And it basically blocks the reuptake of a certain type of receptor. So it does this competitively, and your body makes more of the receptors, which is why Botox wears off. And so there's no downtime. Occasionally I catch a vein, people get a little bruise, but it's pretty uncommon. And it's useful for reducing dynamic wrinkles. We'll talk about that. Dysport is another type of botulinum. It's just bound to a different protein. And the reason that Botox is more popular is because Botox has a better legal department, to be honest with you. They kept Dysport out of the United States for about 10 years. It was used in Europe. So it's a great product. So if you want to get Dysported, you can too. So we say results last 3 to 6 months. So again, your body can't keep up with the receptors after a while. So a lot of times people can go longer in between treatments, and sometimes up to 6 months. Not that common, but usually what we'll do is we'll have you come in for the 3 month, and then if you still look like your motion's reduced, then we'll maybe add another 2 weeks, and we'll find a point that we get to with that. So, so we talk about forehead wrinkles. People call them the racing stripes. Glabellar wrinkles, people call them the 11s. And then the upper nasal wrinkles are called buddy lines, and then periocular wrinkles we call crow's feet. So those are what we typically target. There's some lower face stuff I'll show you in a second. And so sometimes people say to me, well, I have this wrinkle at rest, and will Botox do me any good? And the answer is yes. You know, it may not, in some cases, work right away, and there's sometimes we can add a little filler with it, but if you use Botox repeatedly, you won't make that face for a year or whatever. That will get resurfaced, and it does make a big difference, even in patients with a more advanced stage of aging. So common injection points. So we have, up top, we have the forehead. And again, we want you to be able to move your brow. So we give it, that's an area where people still like a little motion, but I can raise your brow, I can drop your brow, I can raise one side, I can raise the other. So it's kind of a cool thing that you can do. The 11s here, nobody misses not being able to do this. You know, a lot of times people say, you look so angry. So we can take care of that. And then we talked about the eyes. You can reduce some of the motion of the upper lip as well. We use very small amounts of Botox. And actually, interestingly, they've shown that over time it kind of reprograms the brain so people don't pucker quite as hard. And then these other injections, so there's a muscle called the DAO muscle. It turns the corners down. We can put a little bit of Botox there to turn the corner up a little bit. And then this muscle is called the mentalis. That kind of pinches and gives you that little orangey kind of look. And we can take care of that as well. Those maybe don't last quite as long. And a lot of times I won't, some of those lower injections I may not do on a first appointment with you, just kind of let you get your feet wet with some of the other less advanced injections. So, And then this is actually Christy from our office when she first came. She had kind of deeper wrinkles. You can see they were across the top. I mean, not deeper ones, but you could see she had wrinkles. And then she looks natural and rested. She can still move the corners of her brow when she's talking to patients. So we try not to freeze you too much. So some things to think about: no downtime. Generally, the first treatment takes the longest to work, and it lasts the least amount of time. I always tell patients the things I don't want you to do are lay flat or heavy exercise, like really hot yoga is a bad one. So I had a nurse come in. She was just coming off the night shift, and she was planning to go to hot yoga later. So like that's probably not the best time to do your Botox, but anyway. And then I used to tell patients, if I haven't met you before, I'm going to do the lowest amount I can because it's your hard-earned. I can always have you come back and add more, but I can't take it out, you know. And that's the other thing I hear when patients go into some other offices. They get nailed for like, you know, hundreds and hundreds of dollars of Botox, and we won't do that to you. Transition to facial fillers. Facial fillers taking care of more of static areas, lower third of the face areas. And again, even since I last gave this talk, there's so many out there on the market. But basically, they're broken down to three major types: hyaluronic acids, calcium hydroxylacetate, and polylactic acid. Okay. And then they used to use more permanent materials. There's a couple that are coming back on the market, but a lot of times those would extrude. So people are like, oh, it's not going to last forever. Like, well, that can be a bad thing. So what the permanent materials did is they incited an inflammatory reaction, and that would help produce collagen. But over time, sometimes that would work its way to the skin and cause some really bad problems. So anyway, these are all absorbable, and they're all something that your body makes anyway. So places we use them: nasolabial folds, jowls, smoker's lines, make lips bigger, smooth out orbital rim issues, and then make the cheeks look bigger. I don't do a lot of cheek lifts anymore, cheek implants, because you can do it with a filler, and the fillers last a pretty good length of time. So now, hyaluronic acid, there's a ton of them on the market. Okay, hyaluronic acid is part of the collagen bath. It's something your body makes. When I was in medical school, I wrote a paper about fillers, and at that time we only had bovine collagen. You had to get skin tested twice to do that, and that was just, I'm not that old. I mean, it's just amazing what we have now. And so they basically think of them as like different shaped ice cubes. Okay, so there's some are chunks, some are chips, and they have different qualities in terms of how much water they encourage. So some are a little plumpier than others. So the small particle ones are things like Restylane Silk, Bolatero, and Restylane Refined. So Restylane they have a whole buffet of them. And the medium-sized ones are Restylane Define, and Juvederm. And then there's a couple large particle ones, Voluma and Restylane Lift. The bigger the particle size, the longer something lasts, and the deeper you want to place it. So something like a fine line or wrinkle, you certainly won't want to put Voluma in there. And you wouldn't want to augment a cheek with Silk. So this is what Juvederm, and again, a lot of these results will be subtle, but again, you want to look natural. You don't want to look like, kind of like that with your face looking kind of cakey. So that's a nasolabial fold, so you can see their folds are more accentuated on the left than the right. This is Restylane Silk to the orbital rim, so that's a thinner filler. And you can see here that camouflages that nicely. One of the things that produces that is the cheek mound descends, and that pulls volume away from the orbital rim. So we can add a little bit of volume into that to smooth that out. Plan a few days for a little bruising, though. So the second class is calcium hydroxylacetate. That's a lot of stuff. That's Radiesse. It's a class unto itself. So that actually is a material that your body makes as a component of bone and collagen. So it's something that's naturally made. They put them in these microspheres you can see up there. And so it does a couple of things. It gives you immediate volume, but then your body actually produces collagen, which is that second picture. And then as the microspheres are broken down by the body, which is that third picture, you have collagen production. So it's a nice combo. You get volume from it, but you also get good collagen production. So it's probably my favorite in the cheeks. Works really good. So the other place we put it, I like to use it over bone because it's thicker. So pre-jowl sulcus in this marionette region, so we always lose a little volume over here, the jowl. So if you have a mound, a divot, a mound, we can put some in there. So that's what you see there. And then cheeks. And so this is actually the only product. You can use Voluma and Restylane lift in the cheeks, and those last about 2 years. But this is the only product that really gives you a lift because of that collagen production. The other thing nice about it, almost all the fillers are come in a 1 milliliter syringe. Radiesse comes in a 1.5. So it's a really nice deal. So I like it. Some offices don't like to use it because there's an antidote for hyaluronic acid. It's called hyaluronidase. And there's not really an antidote for Radiesse. So if you're not confident about what you're doing, then you probably wouldn't want to put it in someone's face. But anyway, I like it. And you can do hands with it as well. It's a really nice product, and it lasts about 1.5 to 2 years for that. Yeah, it works really nice for that. I am a facial plastic surgeon, but I can use a needle other places on occasion. So Sculptra is polylactic acid. So we go to the gym and our muscles get sore. Turns out if you string those molecules together, it stimulates collagen production. So it was originally for patients with HIV-associated lipoatrophy. So, you know, I've seen all these commercials now for these HIV drugs, and it's amazing what we've accomplished with that. It's a chronic disease, but there are still consequences to having that disease, and one of them is you lose volume in your face, so they approved Sculptra for that. But then they had the idea that, well, if it works in someone with no immune system, then maybe we can try it for cosmetic purposes. So it's unique, even more than Radiesse. It helps your body produce collagen. And the results can last anywhere from 2 to 5 years. However, the downside is you have to come in usually 3 times to accomplish that, usually at 2 vials. So it's a little spendy, but it really does work well. And I say there are global improvements. So if someone comes in and say, I don't like my nasolabial fold, well, we can put a filler in that. But if someone says to me, well, I want to put my face in a better balance, then we can add little bits of Sculptra in a lot of different places. If you see someone that has Sculptra, like this gal here, you might not know what she had done, but you can tell that she just looks better in that picture. And then this gentleman, he had quite a bit of volume loss, and we filled in his cheeks and his prejowl sulcus and his temple region too. That's an area I like to use Sculptra. People neglect that, but when you look very hollow here, it makes you look older. Okay, so that's volume. Now we're going to talk about resurfacing, things to increase collagen production directly. And so, again, we're going from more basic stuff. So we have an IPL machine, which is intense pulse light. I call it diet laser. It emits a wavelengths of light. So a laser usually emits one wavelength of light in one phase, whereas IPL emits a range of wavelengths. So it's really good for sunspots, active acne. We have a different tip that can do hair removal. We call it semi-permanent. And it can help with other color issues. Works better in patients that are lighter skinned. We can use it in patients with a bit darker skin type, but the machine is looking for the discrepancy between pigment and the surrounding skin. So obviously the closer those are, it's harder for the machine to pick up. And it only works for dark hair, again, because we're looking for that color. Usually done a series of 3 treatments. Hair removal is about 6, little to no downtime. You need to be careful about sun exposure because we've just stimulated your skin. You will pepper a little bit, so all those little brown spots that you have will get taken up by the machine the first time you do it. And it's a useful adjunct to more aggressive laser procedures. So sometimes there's not one thing that'll help you, but a bunch of things. And so the way it works, a laser will hit the skin directly, but IPL will scatter, so it doesn't penetrate as deeply into the tissue, so not as much downtime. And this is Stephanie. When she started working for us, of course, the nurses had to hit her with a machine. So you can see that it did a lot of improvement in her sun damage there. And then this is another patient. You can see how it helped lighten up her sunspots. So dermaplaning is something new that we do. And basically, it sounds like a scalpel, but we do use a scalpel. This is done by our nurses. But it's just like you're shaving. It takes that superficial layer of skin off, like the peach fuzz. And the nurses have had a lot of patients be really happy with it. Just gives your skin kind of a little more glow to it. There's really no downtime with it. It's very relaxing. Chemical peels, we do have those too. So a lot of the things we'll talk about have supplanted that, but we do have some more of a superficial peel line that you can use as well. And basically that is chemically removing the superficial layer of the skin to increase collagen production and skin cell turnover. That's a peel. So microneedling has supplanted a lot of things. And so what we do with microneedling, and this is again done by our nurses, and a lot of offices do it, but I always say just because you have a pen doesn't mean you're a writer, okay? So you have to know what you're doing. And so when you come in our office, a lot of times people have had it done elsewhere and they're like, wow, that was a lot more involved than I thought. And That's because our nurses know what they're doing and they're going to give you a good result. So basically what the pen does is it makes little penetrations into the skin, very little discomfort, and it increases skin cell turnover. It can help with fine lines and wrinkles, acne scars, skin discoloration. And we have something called platelet-rich plasma that you can do with it. We take a little of your blood and we spin that down, and that's applied to the skin. We do that for a lot of different things. PRP, you may have heard about it for bones and joints and stuff. So when you get a cut, your platelets are what heal it. And so we can use that to increase the rate at which your body heals these things. So it cuts the downtime about in half for a lot of this stuff. So some microneedling results. I was looking through, I did this over the weekend, so I didn't know who had signed, but I know this lady had signed, so that's why she's up here. But you know, it's a nice thing to do when you don't want a lot of downtime. You want to just improve the way your skin looks or the coloration of it. So lasers are another way to do it. Microneedling does it with light, peels with chemicals, and lasers, microneedling with mechanical, and then lasers are with light. And so they're lasers. We could talk an hour about lasers, but I always give people my laser 101, so we'll talk about that. So lasers basically have to go through the epidermis and the dermis, and they penetrate to varying levels. So there's different wavelengths, and you can capitalize on that for different purposes. There's some offices that have 15, 20 lasers, like in a big city, but we don't have that here. So so things that are on the shorter spectrum would be more pigment issues down there where you have argon, KTP, and dye. And then as you get longer, you're getting more skin tightening, more aging, resurfacing kind of thing. And then carbon dioxide we'll talk about, but you see the wavelength is 10,600 nanometers versus IPL, which is usually in the 5 to 700 nanometer range. So they do very different things. So all lasers now are what are called fractionated. Lasers used to be flat beams, so when they hit the skin, it was like a postage stamp. Now when we hit the skin, it's more like a checkerboard. So someone had the idea, well, if we treat less of the skin, does it cut down on the downtime and risks associated with it? And the answer is yes. So when you hear fractionated lasers, that's all that means. So flat beams were very effective, and we still do them for some purposes, meaning we treat 100% of the skin for certain things, but most of the time we'll fractionate it. So we treat usually about 20 to 40% of the skin, depending on what your problem is. So that's just an example of that. Postage stamp, checkerboard, or chess, depending what you want to do. And so the next phase was someone asked the question, well, do we have to take the skin off? Can we treat the deeper layers with leaving that epidermis on and give still people improvement? And that's what the non-ablative lasers were. So there's a lot of R&D with this, and we do have one, and there's a lot of good ones out there. In general, they don't do quite as much as an ablative laser, but they don't really have a lot of downtime with them. But a lot of offices do them because they can be done by a non-MD, and so you just have to be careful, do your homework about it. And so here you have, this is the example, you have ablative, hits the skin 100%, you have superficial fractionated, and then you have non-ablative resurfacing. So what that's doing is that's treating the tissue but not taking the epidermis off, and then you have fractional ablative, so it takes the skin off down to a certain level. So non-ablative lasers, again, a lot of R&D. We do have one. It's called sublative. We usually use it mostly for patients with acne scars. Microneedling has done a lot of what that machine will do, but it does work well for certain purposes. And so fine lines and wrinkles, dyschromia, meaning skin discoloration, usually done in a series, very little downtime. Complications are infrequent. And so this is somebody that we did a non-ablative laser on. Just kind of cleared up her skin a little bit, just tightened things up a little bit, but not a lot of downtime. Another patient, you can see top and bottom, just some improvement in her skin tone, texture, a little bit of tightening of her skin. So ablative lasers are the more powerful tool. They should be done by an MD, not always, but should be done by an MD or a nurse practitioner, somebody that has a license to practice on their own. Common indications are wrinkles, loose skin, and acne scarring. We usually do ours with a little bit of, not conscious sedation, but we'll give you prescriptions for stuff just to chill you out a little bit. We have numbing cream that helps as well. And sometimes you can do it in combination with surgery too. Ours is the core, which is the CO2RE. It's carbon dioxide. So carbon dioxide is pretty much the gold standard for all ablative lasers. And the long wavelength gets taken up by water and hemoglobin to allow deeper penetration into the skin versus erbium. Erbium is the other ablative laser. And I won't say any names, but I used to do erbium. Erbium doesn't work as well. And a company packaged erbium to this new latest, greatest thing, but it's okay and it works pretty well, but it's not the latest and greatest thing. It was circa 2007. And so what it does is it has a shorter wavelength, 2940, so it doesn't penetrate as deeply. So the downtime isn't quite as much, but you also don't get as much skin tightening as you would with CO2. And fractionated CO2, the knock against it used to be complications like pigmentation issues, which are very uncommon now with the fractionation that we use. We can also treat lesions with it, like sebaceous hyperplasia. People come in with those bumps. We can just zap those away. And then sometimes other little superficial lesions that the people just want taken care of, we can do with that as well. And we can also use PRP. So this is an ablative laser. So think of moderate lines and wrinkles and increase in tightening of the skin. We can do deep wrinkles, but that usually requires a little more energy, a little bit more downtime, a slightly higher risk of hypopigmentation. So I can dial up to the machine to just about any setting, and so that's a nice thing about the machine that we have. And so this is just some acne scarring as well. That's done in a single treatment though, which is good. Non-ablative, very little downtime, ablative a little bit more. And then you can get hyper and hypopigmentation, so that means the skin turns darker. That's always temporary, very uncommon with CO2, very common with erbium. Hypopigmentation, I have seen it, rarely. That's when the skin is lighter than the surrounding tissue. That doesn't go away. But thankfully, maybe twice in 12 years I've seen it. It's really uncommon. So that's that. So that's lasers. Okay, so think microneedling, IPL, and lasers are things that are going to resurface the skin. All therapy works a little bit differently. It's going to target the fascial tissues, the deeper tissues. It's like the laser has to pass that energy through the skin, whereas all therapy goes to the deeper tissues. And so like a laser can go to about 1 to 2 millimeters of depth. All therapy can get to 4.5 millimeters. And the reason that's important is the fascial tissues of the head and neck are at that level. So it can cause some small damage there to lift and tighten. Usually does so over about 3 to 6 months. And some people, so if you go to like Real Self online, you can see, there's mostly positive reviews, some negative. The two major reasons for that, I think, are poor patient selection. So like if you need a facelift and if you have a lot of skin redundancy, old therapy is probably not your best choice. If you have mild to moderate, it's probably a better choice. And then you have to be able to read an ultrasound, as it turns out. And when the machine first came out, they tried to make it sound like it is idiot-proof. But then they did a couple of retrainings where they found that most of the offices couldn't read the ultrasound. So that's kind of problematic. So it uses the ultrasound to lift and tighten the collagen. Christy Brinkley's their big spokesperson. I think there's a little genetics involved too, but she looks good. So areas we can target, we can do full face, we can do full neck, lower face. That's probably the most common one we do. We can do your décolletage. Works really nice for that actually, because there's not much else you can do for that, or the lower neck. So those are things that we treat with that. Works well for the brow. A brow lift will get you about 4 or 5 millimeters of lift. All therapy will get you about 2. So that's pretty good for a quick little procedure. I don't do it around the mouth unless we're doing it in combination with laser, because it just doesn't do enough. But if you do it with laser, they can really help. The neck add-on. So basically what it's doing, it's just showing you that beam gets focused on that deeper tissue down there, or see below the fat layer there. And then you get improvement over 3 to 6 months. It's slow enough sometimes that people don't really notice it until we show them pictures, though, because the results are subtle, which is good, I think. But there's no downtime with it. There's no recovery. We do give you some medications, but it's a pretty nice procedure and adjunct to have. Uh-oh. Well, she looks better. Sorry. I got a couple others. So anyways, that's a lower neck one. That's before and after 90 days. And I had another one on there. I guess Gwen took some off because they were pixelated. But in some patients, it can be very, very noticeable. Most of the time, it's a subtle but noticeable look when we look on the before and after pictures. But it's a nice thing to adjunct. So other things that are out there now, Kybella, which is deoxycholic acid. So that's usually done in 2 to 3 treatments. It's an injectable. It does take the fat down. So there's like 4 grades of neck laxity. It takes you down about a grade. And then we have slim liposuction, which is a laser liposuction. It emits 2 wavelengths of light. One wavelength emulsifies the fat, breaks up the fat. The other wavelength tightens up the skin. It's done through 2 little incisions. So Kybella, you might recognize her. She's in the back of the room. It's done through a series of injections. We usually space them a month apart. That's, I think, for patients that don't want any surgery. They're looking for just a little bit of improvement in the fat. And it's great for younger patients with more of a congenital fat as well. So there's a Kybella outcome. If you want more than 1 grade of improvement, sometimes it takes 3 or 4 treatments. And then it's like, well, why don't you just have, why don't we do slim lipo? It takes me 45 minutes. So if you're looking for something non-invasive, it's a good option, though. So slim lipo, again, it's a laser liposuction. It looks like a little conductor's baton. It emits 2 wavelengths of light that are at maximal take-up for the dermis, skin tightening, and fat for fat removal. We do it through 2 3-millimeter ports. It takes about 45 minutes. We ask that you try to wear a jaw bra for a week, but we're really rigorous about that the first 48 hours. But there's just 2 little incisions, and you get improvement of about 3 to 6 months. But it's really a nice thing for patients that don't want or need a facelift. So this is a miraculous result. I'm just telling you right now, that's not like my average. So I probably shouldn't even have that on there. You should have your average results. This is a good one, though. This is a lady that was a little younger, and she had some nice improvement with it. So again, I do surgery. I love to do surgery, and people get spooked by surgery because they don't want to look done. They're like, I don't want to do this, this, and this because I don't want to look done. So our goal is to make you look nice, natural, and rested. So anything we do to you, we're going to do because you need it, and we're going to do it so hopefully other people won't notice what you had done. And if they do notice, it will be something like you look more rested, you look better, I can't tell what's different about you. That's what I'm going for. Not like, who did your facelift or who did your brow lift? We just don't want that. They say Montana's a small town with a long main street. If you don't do good work here, they're going to run you out of town on a rail pretty quickly. So anyway, and then again, you treat everybody like they're your neighbor, right? So we don't want to do things to you that are going to compromise your health or anything like that. So upper lid blasts, I do a ton of those. They can be sometimes covered by insurance. You have to have a visual field study done by an optometrist, and there's different criteria from different insurance companies. You can combine it with a brow lift if you have brow ptosis. I always tell patients when you have extra skin, it's usually a combination of 2 things, gravity, pushing the brow down, and loss of elasticity. So it just depends on how much of the brow is an issue, whether or not we address that at the same time. Downtime's typically a week. For cosmetic purposes, we do in the office. Usually we'll do in the OR for insurance, just for different reasons. And incidence complications very low. So nice subtle look. The incision's very well hidden. Nice subtle look. Nice subtle look. So yeah, it's a nice little procedure. And so brow lift. Again, sometimes patients come in and they have a lot more of a brow problem than an eyelid problem, and this is something to point out to them. A lot of times when people have extra eyelid skin or they have a brow problem, they walk around like this, so that gives you those deep wrinkles. And if you just do an eyelid lift, then a lot of times you'll still have extra skin, so sometimes you combine those 2 together. Medicare does cover some brow lifts, but no other insurance companies do. There's many approaches. The coronal, which I don't do, that raises your hairline, gives you a long scar. I think that's what those other ones were. No, thank you. So endoscopic is we do 3 small ports and then 2 longer ones done in the hairline. And pretritial, those are the most common cosmetic ones. We can do a mid-forehead and a direct lift. Sometimes we do those for functional purposes. They say that we're not supposed to do those in a woman, but I always say you probably never met some of the Montana ranching women. You could definitely do a mid-forehead in them, and no one will ever see it. So the endoscopic and pretritial are the most common. So pretritial is in the hairline, endoscopic is behind the hairline. The endoscopic lift is great. It's hidden, but it does raise the hairline slightly. So patients with high foreheads or sloping foreheads where I can't get the instruments in, not the best choice. Pretritial's in the hairline. We bevel it so the hair grows through. So it's good for a patient maybe with a higher hairline. The scar on the pretritial is a little bit longer, but it heals well, and we can do that in the office. So just a couple of brow lifts. Again, that was a lady I did her neck, but I did her brow too. She had a pretty good outcome. And you can see it just makes you look rested. She doesn't look like she walked into a surprise party or anything like that. Lower eyelid blefts. A lot of people shy away from these. My thing that you should be aware of is that gravity's working against us, so I might be able to get you 99% what you want with an upper, probably 50% of lower, because we have to be very conservative and respect that. But given that, as long as you know your anatomy and you don't over pull, over tighten, it's a really nice procedure. It can address malar bags, extra eyelid skin, poofiness of fat. And we'll talk about that at a consult about whether or not that's a good choice for you. Some patients, it's not that they have fat that's sticking out, they just need more fat below, something like that. So anyway, so this is a younger patient. You see she had the bags before, and then after her skin just looks much tighter and just more natural. So it's a subtle look, but it's a nice look. We can either do it from behind the lash line in younger patients for just fat. In older patients, we usually like to do that external incision so we can resuspend some skin and muscle. And we shore everything up to make sure that you don't walk around like that. So that's another patient. This kind of improves her bags. Just a subtle improvement, but just a nice outcome. So chin implants. So if you have neck laxity and you don't have a chin, I can put a chin implant in. And that's the lady who had a chin implant. You can see she had neck laxity, but we put the chin in. I did her nose too. Pretty good. So facelift, we'll end with this. So there's a lot of things out there about facelifts. People don't want to look done, but it's a time-tested approach. It can have dramatically address jowling, neck laxity, and some mid-facial stuff as well. And there's lots of confusion because people have different nomenclature for this. But so a traditional facelift is done with an incision from the ear to behind the ear. Mini lift is usually done through a smaller incision or an S lift. Just to show you quickly, I'll get to that in a second. My mini lift is not really a mini lift, it's called a max lift, which stands for minimal access cranial suspension. And so that was developed by a guy in Belgium, and he figured out you can use a smaller incision if you pull in a different vector. And so that it's a good option for patients who don't need a full facelift, or we can combine it with some other incisions to give you a little bit more improvement. And it's pretty quick operating room time, and it's a longer lasting than some of the other mini lift options. And so a mini lift is up there. That's kind of an S lift. So you can see the incision up there, and there's just a little bit of dissection. So you're going to get a few years of improvement, mostly in the jowls. The max lift you can see through the same incision, but you can see the extent of the dissection is more. We use purse string sutures, so we give you a more durable result through a smaller incision. And it doesn't take me much longer to do that. Some patients are not candidates for that. If you have really thin skin, if you have a lot of crepey neck skin, you might want to have a traditional facelift. So downtime's 1 to 3 weeks. The risk of complications is very low. Flap loss, not had a problem with it, but it's at 1%. Hematomas, 5%, not had a problem with it. Nerve damage, I had 1 in 12 years, was temporary. The risk of that's like 1 to 2%. Permanent would be 10% of that. So there are risks, but it's a great procedure, and to show you a couple outcomes here. So this was a patient that had it done just in front of the ear. You can still see there's some neck laxity, but a pretty nice improvement from a small incision. And then this was a gal, I did liposuction her neck as well, but you can see it really clears up her jowls, and it does help a lot with her neck laxity as well. If you go into someone's office and they show you facelift pictures with the hair down, go somewhere else because they're hiding their incision. So we like you to be able to wear your hair up. You want to shave your head, you're good to go. And then this lady was more of a traditional facelift. So she had a lot more laxity. So I basically did the max lift, but I did an extra incision back here, did some liposuction in the neck. And you can see it's a pretty nice improvement. So anyway, we offer a lot of stuff. I know I went through a lot of stuff, but it's pretty cool now, all the stuff we have available for you. And we'll tailor the treatment what's best for you, not what's best for us. And that's really all I got.